Good evening to everyone. I think welcome all of you in this HOCM symposium. We have got a faculty is very good. And I think the first introduction or welcome speech will be by Dr. Kani, our president for this year. He is from Goa Medical College and presently from KEM and is attached to Shushusha Hospital, Dadar. And we wish to start the talk with Dr. Kani, sir.
Friends, welcome to this very interesting webinar on new frontiers in hypertrophic cardiomyopathy. This is a topic which is very close to my heart because I'm always interested in this subject. It always sort of confuses me many times. So to sort out all the issues, we have excellent speakers who have tremendous experience, and we have chairpersons who have done a lot of work in our city and the country. And without wasting time, let's go and listen to them. So I now hand over to Dr. Dargad, who is our coordinator, to carry forward this whole program.
Thank you, Kane sir. So I think first we're starting with the genetics of hypertrophic cardiomyopathy. And we have a very excellent speaker who has worked a lot of work in the genetics field in the US, actually last 15 years of experience. He has been the student from the Mumbai only, Terana Medical College. And then he's been with John Hopkins and a lot of institutes. Presently, he is working with Jackson and he has developed a lot of multiple his research project with the genomic service delivery, specifically in a cardiac and oncology. He has a lot of interest. His extensive development in the regional networks and interdisciplinary training initiative. And he has contributed different in the counseling also. He does a lot. And he has visited India, Mumbai, and he has been our speaker in one of the previous meeting, also in ICCON meeting. I have called him that time hypertrophy genetics. He has spoken 5 years back, actually. So over to you, Kunal, to talk on the first talk on the genetics of the cardiomyopathy, hypertrophic cardiomyopathy.
All right. Well, thank you, first of all, Dr. Dargar, for this opportunity. And it's really humbling to be presenting amongst a distinguished panel here. I wish I had sort of the bandwidth to listen to all the distinguished speakers, but I will do my best to commit to talking about the genetics of hypertrophic cardiomyopathy. All right, let's dive in. This is going to be a snapshot of genetics in hypertrophic cardiomyopathy. As Dr. Kane sir said, this topic confuses most clinicians and practitioners likewise, and researchers as well. This should be viewed as an overview of genetics in hypertrophic cardiomyopathy. This everybody knows, but to kick off the discussion here, the important part when it comes to genetics is the family history. So when you have family history, the parameters changes a little bit, which we now know that the wall thickness need to be more than 13 to 15 millimeter as opposed to the conventional 15 millimeters, just to emphasize the importance of family history when it comes to diagnosing hypertrophic cardiomyopathy. We all know that it is apparent around adolescence, could be early adulthood, but there have been cases where infancy and later onset has also been observed. Clinical manifestations are highly variable, and disease expression and penetrance can vary within the same family. Of note, particularly, the penetrance is estimated to be 50 to 62% in at-risk relatives who have a pathogenic variant identified. And when we talk about different genes, studies have shown that there is different penetrance for different genes that are associated with hypertrophic cardiomyopathy. Now, continuing that part, the prevalence is 1 in 500. Most idiopathic forms are genetic. There are two forms, as we all know. 2/3 cases are obstructive, 1/3 are non-obstructive. Collectively, when you think of heart diseases, 25 to 50% have no prior heart medical history. Now, this number is approximating for HCM as well. The two most important genes that we need to think of are MYBPC3, that has about 50% of cases attributed of HCM cases are attributed to this gene, and 33% are attributed to MYH7. Now, genetic testing can help save lives. When we go further, we'll know what is the important area of genetic testing here. But by and large, it's not monogenic where you have a single gene of causation that you can approach any treatment in a particular order. There is a lot of pleiotropy and heterogeneity that exists. Now, 60% of patients in one study experienced a misdiagnosis prior to receiving a definitive diagnosis. So that calls for the need for clinical suspicion to think about HCM, and genetic testing plays a little bit of role there. Sorry. Okay, so these are the important genes that are attributed to HCM. We talked about MYB, PC3, and MYH7. The there's a there's a consortium that sort of looked into these genes and attributed the frequency and inheritance pattern. Most genes are inherited in an autosomal dominant fashion. And when I mention about the penetrance, overall penetrance, the highest penetrance is observed for MYBPC3 and MYH7. Other genes are likely very variable. What it means is if a mutation is passed on from one generation to the other, it's not necessary that 100% of the time it will manifest itself. And that's the penetrance percentage that we're talking about here. Now, this slide sort of gives you a sense of how many genes have been attributed to different cardiomyopathies here. Now, three concepts are very critical to understand when you think of genetics of any heart diseases. One is a locus heterogeneity. What does it mean? It means that there are mutations in different genes that cause a similar phenotype, which is a clinical manifestation. Other concept is allelic heterogeneity, which means that there are different mutations within the same gene that could cause a particular clinical manifestation or a phenotype. The other heterogeneity is phenotypic heterogeneity, which means different mutations within the same gene can cause different phenotype or different clinical manifestation. Why is it important? When you think of risk stratification or thinking of clinical management, some of these aspects of genotype phenotype correlations have known to sort of help with clinical management. Now, what are the benefits of testing? When you think of genetics of HCM, the primary role is for cascade genetic testing. Does it impact the clinical management? To some extent. Does it impact the sort of the predictive nature of the prognosis or the patient management part? Yes, and there is emerging evidence for it. But as of now, the primary role for genetic testing should be in the context of cascade genetic testing, which means testing for other family members. Now, these are obvious. You can confirm a diagnosis, you fulfill a diagnostic criteria, you identify at-risk asymptomatic or pre-symptomatic family members. That's the part that is most critical when you think of genetics of HCM. Now, I want you to look at this picture and think of these concepts. If you already know of genetic testing and the variant, what they mean, that's fantastic. But to recap, the American College of Medical Genetics and Genomics, they designed this criteria of identifying the pathogenicity of a particular variant, a gene mutation, or a gene change. Think of it in whatever terms that suits you. So when a mutation occurs in a gene and it is classified for diagnosis or pathogenicity purposes, the 5 criteria are benign, which you see on the left of the screen, likely benign. The third one, I'll come back to it, but think of it as a monster for now. Fourth one is likely pathogenic and pathogenic. When you have benign or likely benign sort of finding or interpretation of the variants, the reports usually indicate that no further action would be needed based on the genetic testing. When it's likely pathogenic or pathogenic, then you sort of think of the next steps, which we will review in the algorithm ahead. The monster here is the variant of unknown significance. What does it mean? It means exactly what it stands for. We don't know whether the variant or the gene mutation is benign or pathogenic in nature. And labs, researchers continue to run bioinformatics pipeline and evidences to see whether it falls in either side of the spectrum here. You did the genetic testing, but the key part is the interpretation. So let's review what happens. When you order genetic testing for any heart disease or in general for any genetic conditions, you identify appropriate patients first, who would be the best candidate to conduct genetic testing on. Second, you select the best test. You conduct detailed pre-test counseling because it's important to know what are the benefits and risks. By and large, think of genetics as probabilistic or predictive at best. It's not binary in any form. Then you review the results and assess the pathogenicity. You conduct and do post-test counseling. You disclose the results, assist family with communication and predictive aspect of testing, and any further anticipatory guidance that exists. Now let's review the algorithm that is exercised in most clinic. And this was this was registered by the 2024 American Heart Association and plethora of other organizations that created this algorithm. So index case is the best person on whom you perform the test. Then after performing the test, you identify whether the disease causing variant is likely pathogenic or pathogenic. Then you conduct cascade genetic testing in family, which is, identify your siblings, your parents, your children who would be best suited to have benefits of this genetic testing. Then you have either a positive finding or a negative finding. If you have a positive finding, you conduct regular follow-up as defined by AHA. I'm talking only in the US specific context right now, which is every 1 to 2 years of follow-up or with a change in symptom. That is the regular follow-up. If it's negative, you don't have to do anything. You continue with regular surveillance like any general population would get. Now, if you look at the right arm of this flowchart or algorithm, if you have variant of unknown significance, likely benign or benign finding, then you continue to reevaluate the variant. And if it is reclassified, you continue doing clinical surveillance in family. And through that, if HCM is diagnosed, then you follow through the guidelines. This is regular follow-up. And if there is no evidence, then you conduct surveillance. Now, critical part here is you are all clinicians, you know this better. But if the echo is inconclusive, then you go for cardiac MRI. Now, cascade genetic testing. It's also very simple. If you think of the different arms that exist, there is first line testing, and there's second line of testing. Once the proband is identified to have a pathogenic mutation, then you have a targeted gene panel, the list of genes that we reviewed earlier. And I should have clarified, we are talking about non-syndromic hypertrophic cardiomyopathy. There is a whole separate division of syndromic hypertrophic cardiomyopathy that requires a different approach. Again, the same concept. If it is pathogenic, likely pathogenic, you continue doing targeted testing. You don't have to run the panel on the family members. You just have to do the targeted testing. And then you see if the family members had that pathogenic mutation or not. And subsequently, you follow the diagnosis and the clinical management. If the first line does not work, then you have the second line, which is the whole exome or whole genome sequencing. And there is also a new gene discovery always. We have about 20,000 plus genes in the body, and only 15,000 genes have been attributed to a particular disease, either directly or indirectly. So there's a lot of room for research and understanding. And then you look at the inheritance pattern. As we saw earlier, most genes are inherited in an autosomal dominant pattern. But two other patterns have also been reported. One is autosomal recessive and one is mitochondrial. So you need to consider that part. Following the second line testing, you look into the reclassification aspect, see if it's pathogenic or likely pathogenic, and then get to the diagnosis for your family member. Now, we talked about the genotype-phenotype predictor or the genotype-phenotype correlation very briefly earlier, right? It helps in clinical management. One of the studies, slightly older studies, looked at the Mayo Clinic's hypertrophic cardiomyopathy genotype predictor score, and they had a participant pool of 359 patients, and the overall yield of genetic testing was 34%. Now, if you look at the rows listed on the top of the slide, the likelihood of positive genetic testing ranged from 6% when only hypertension was present, that's -1 point, to 80% when all 5 positive predictors were present, and concomitant with hypertension was absent, kind of thing. So there's a lot of variability. So you need to look at in the clinical context as to how you're going to use this and apply. This was sort of a supplemental table that I thought was useful to look at different clinical parameters, family history of hypertrophic cardiomyopathy, and family history of sudden cardiac death. One aspect of risk stratification in the for hypertrophic cardiomyopathy is in the context of sudden cardiac death only. There is research going on to look at risk stratification for HCM based on genetic testing, but that's still under development. The calculator that's available on AHA website also does not have any genetic testing score on it, but it's in development right now. Now let's shift gear towards how do we explain to the patients, right? We talked about, again, think of this as an overview, and happy to connect with you afterwards to sort of go into the details of this testing part. But I wanted to spend a few minutes to talk about how do we get this information to the patient, because that's critical as well. That helps with that adherence. So informed consent is a big part. A lot of research has been done as to why this is important. These are some elements that you need to cover in informed consent part. Talking with parents in our cultural context, it's critical to address the misperceptions that, okay, if you get the genetic testing done, you rule out all genetic disorders. And if you have a defect, there's a way to fix it. No, as I mentioned, genetics is at best ambiguous, probabilistic, predictive. It's not binary in any form. Let's look at this question. Which of this following is true about psychosocial issues in cardiovascular genetics, right? Pause here. Anybody can take a stab. Any guesses what's the right answer here? All right, 30 seconds are up for me. So okay, I see some chat messages here. Let me see. D,
So,
yes.
yeah.
So thank you for responding. Depending on the clinical context and the situation that you are in with the patient, either C or D could be sort of taken as a right answer. C is the best suited one. The most significant is denial. This could be true for some set of patients, but not others, kind of thing. And the first two are clearly disregard for any psychosocial issues that could be encountered by any patient. So important to think about this aspect as well, that research has shown that it helps with adherence of clinical management. These are some of the next set of slides are basically teaching slides that we use with patients just to help them understand more about HCM. If there are other models out there, I would love to learn them from you. But essentially, we sort of give the analogy of a racing car or a car with 4 tires. That's your normal heart. If one of the tires is enlarged, which means one of the chambers of your heart is enlarged, and that's hypertrophic sort of form of cardiomyopathy. Then the symptoms, right? You're catching your breath, you're tired, fatigued all the time. You sort of have a feeling like fluttery or funny feeling sometimes. Then you have strange noises, you're dizzy, your sweets are swollen. The key thing is these are not exclusive to HCM. You could have these symptoms without HCM as well. So that needs to be conveyed. And then just reassuring, it's okay to talk about the symptoms and not feel like, yeah, I'll be fine kind of thing. The other thing is you can't catch cardiomyopathy from a friend, right? Particularly from the adolescent's peer-to-peer kind of situation. This is basic description of genetic changes, right? The cat is in the room. Because of the mutation, it becomes the bat is in the room kind of thing. So it's sort of just simplifying it for the patient and then telling them that it's basically a chance. Autosomal dominant inheritance is 1 in 2 chances or 50% kind of thing. And then the family tree, the pedigree. It's very important to take 3-generation family history when you think of oncology or cardiac cases because it's complex. And then here you see the example, the purple ones are the ones who have clinical diagnosis of HCM. The yellow heart is basically the ones who have mutations. And that's how you continue to explain the patients about these things. These are some of the resources. I talked a lot about variants, likely pathogenic, benign, likely benign. These are some of the resources, NOMAD, ClinVar, ClinGen, that would give you information about the pathogenicity and any mutation that comes up in your test report of genetic testing. The last link, the share registry, if anyone is of interest in research of HCM, they actually invite researchers across the globe to share their findings on variants, and that's how they are creating their own repository just to benefit everyone across the globe. These are some of the guidelines that exist, which everybody knows, and I like to always look at this because it's very complex. Again, quoting Dr. Kane, it's confusing and whatnot, but if you can't face it, then you're not going to change it. Welcome to connect with anyone. Happy to address any questions, and yeah, look forward to working together again.
Thank you, Kunal, for this excellent presentation. It's a good morning for you, actually. And we'd like to comment from the Raju Karnik and Dr. Snehal, anything from their side. So quite interesting talk. I think that simile of the tire was very interesting for me, how you can explain the patient in a staircase way, actually.
Kunal, actually, I mean, it was an excellent talk, and then we do look forward to have this facility, which is currently, which we are not employing. But let us say that it has been 1989 and 1993 that we got to know about this myosin heavy chain 7 or binding protein 3. So it has been more than 30 years, but yet it has not become really popular in majority of the practices. Is it because although you said that it can give little make difference in the kind of treatment or this, but as far as the literature goes, it said that whether it is whichever is the etiology, I mean the beta blocker or hydropyridine calcium blockers or disopyramide, everything will work the same. Surgery will work the same. So as far as the treatment goes, it wouldn't make much difference, even if we know whether it is genotype A or B or C or whatever it is. Secondly, maybe I think for cascade testing or in form Fuste cases or in some of the phenocopies, like we have this TTR amyloidosis or Noonan or Fabry or Dan, some phenocopies where we get confused and we see the hypertrophy, whether it is hypertrophic heart, because hypertensive heart disease, or whether it is, we are not very clear. So in those cases, how do you think this will be, how much it will be useful? Because again, here the detection, even with whole exome sequencing, how much would be the detection of the disease in this form Fruste cases and cascade testing?
Yes, sir. So if I understood your question correctly, like whether the genetic testing results would help with any clinical management, correct? The two examples
Yeah.
that you gave. At best, the best answer right now I can give is that the research is emerging, that there's growing evidence that the genotype will help inform your clinical management. Like, for example, MYH7 is known to have early onset, right? MYBC3 is known to have later onset, kind of thing. There is a male predominance, correct? So these actions sort of help with preemptive measures to approach clinical management in a specific way. Does it inform your pharmacotherapy? Probably not at this stage, right? There is a separate arm of that is looking into the CRISPR, like the gene therapy for HCM. Fun fact, like there are 26 gene therapies that are already approved, and there are 2,000 plus gene therapies that are being developed right now. So HCM is a candidate part. The preclinical studies have shown a lot of promises. It's just testing the safety and efficacy of this in HCM. So short answer is no, it does not help with your clinical management or deciding what treatment or therapy to use right now. Uh, but it helps with the cascade testing only, like how early you can pick up your family members and how early you can start clinical management for those patients, kind of thing. But I would not disregard knowing this just because of the difference in clinical manifestation and the benefit that it might have with early surveillance.
Yeah, and just one more.
I think
Can I
Snail
add
has
one
any
more?
comment. Actually, I have said something.
Yeah.
Just and I
Yeah.
think we have a lot of time. We'll have to rush
Yeah.
report. At the end, I think Kunal will be with us sometime, and we can talk at the last panel discussion sometime. Snail, any comments?
Yeah. Thank you, Karne sir and Cardiology Society of Mumbai for inviting me. Thank you, Kunal, for your talk and a summary. I just wanted to inform that we have currently many families where we are, first we have to quickly, within 1 minute, I would like to summarize that we have to first say with the sarcomeres, that the HCM phenotype, and as Dr. Rajesh said, that HCM phenocopies. So first we define HCM phenocopies, and we have been, I have families who have, we define with HCM phenocopies, then we decide whether it is Noonan phenotype, and then we apply whole exome sequencing, and we have diagnosed family members and fathers affected. Then we have infants coming with cardiomyopathy and parents carriers, and we have been tracking them for managements. And we also have families where we are detecting adolescents, where we are putting them on surveillance with cardiologists. And we also have patients with Fabry disease where treatment is available. So there are treatments where are available, enzyme replacement therapy, amyloidosis, where you have to then track systemic complications. And I recently had a child with adolescents with autism, and then presented with surveillance detected hypertrophic cardiomyopathy. And when you can't have whole exome sequencing, we are suspecting Friedreich's ataxia. So you have to have that kind of clinical, what we call it as human phenotype ontogeny. So define your phenotype, apply genetic test, then cascade testing and management. So we have been, many families are being impacted with this management and genetic counseling, and especially family planning, where the cases are very early presentations. They're coming forward with their queries. Thank you.
Thank you. I think we'll go to the next talk. Kunal, thank you very much. And you'll be with us for some time. I think we'll later on.
Sir, can I quickly address this? I know we are moving along with the agenda. Thank you, Snail ma'am, for sharing this thought.
It's 9 o'clock.
I wish I had more time to talk about the syndromic aspect. We only focus on the non-syndromic aspect of hypertrophic cardiomyopathy, and pediatric division is a whole different arm with a lot of guidelines as well. But this experience is very helpful, and I'm glad you are doing that. So thank you very much.
Thank you, Kunal. I think for the next talk is by Dr. For the radiology, Nitin Kule, sir, and he's from Jupiter Hospital, Thane, and he's been quite active in the Eco Society. He has organized the last time equipment. And to chair this session, we have three eminent persons: Robin Pinto from Holy Family in Lilavati, Dr. Shekhar Pande from Hinduja Hospital, and Dr. Alpha Bharti, radiologist. All the three panelists, I'll request them to join. And Nitin, to start is the imaging in HCM, which will cover the echocardiography with MRI also. So I think we have 20 minutes. I will try to finish off as well.
Thank you, dear friends and teachers. Are my slides visible?
Yes.
Yes, sir.
Yeah. So the imaging in the hypertrophic cardiomyopathy involves the diagnosis and monitoring, the prognosis and risk stratification, looking at the heart failure phenotypes in the hypertrophic cardiomyopathy, evaluating the LVOTO in symptomatic patients, and evaluating for the eligibility of the septal reduction therapies. As we know, the HCM diagnosis traditionally had been the maximal end diastolic wall thickness in adult 15 millimeters or more in any part of the or any segment of the left ventricle, or 13 or 14 millimeters in the family members of the proband, or if you are genotype positive. And for the children, it is Z-score more than 2.5 in any segment, and more than 2 if you have a family member with or you are genotype positive. There are different contours of HCM which are very interesting to look at, and we have this reverse curvature, which is the convex septum. Then we have got the sigmoid septum as HCM. We have got this neutral looking septum, and we have got apical HCM. And interestingly, the frequency of genetic mutation is highest in the reverse septum, and second best is the neutral. And obviously the major pathogenic gene is MYBPC3 and MYH7. There are certain additional helpful features when you look at the images. One is the systolic anterior motion, the elongated mitral leaflets, the hypertrophied or apically displaced papillary muscle, the myocardial crypts, as you can see in this MRI, the anomalous insertion of the papillary muscle in the AML, hypertrabeculation, especially on the lateral wall, the myocardial bridging, and the right ventricular hypertrophy. There are further additional helpful features. One is the heterogeneous strain maps, as you can see here, the strain dispersion, the intraventricular dysynchrony, the reduced longitudinal function like reduced GLS, reduced E prime, A prime, and S primes. ECHO is the class 1 indication for the first diagnosis, family screening, monitoring the proband every 1 to 2 yearly, or if you're genotype positive, then below age of 18 years, 1 to 2 yearly, and thereafter 3 to 5 yearly. Repeat, obviously, if there is any change. In symptomatic patient, it's important to do the provocative maneuvers, and ECHO also useful for the intra-op, intra-cath SRT procedures. The echo contrast is a class 2A indication, but it's very useful for picking up the mid-cavity obstructions and also the LV apical aneurysms. CMR is obviously a class 1 indication, especially when the TT is inconclusive, when you are thinking of an athlete's heart or a phenocopy, you want to refine the SCT risk, especially for the late Gallon enhancement, planning for the septal reduction therapies. A follow-up CMR may be considered 3-5 yearly for refining the SCT risk. CMR has an additional tool of myocardial characterization, and that is lead gadolinium enhancement. The gadolinium retains in the fibrotic area, and it is seen as the intense white signals in the LG images, and that gives you an idea and extent of the fibrosis. And these LG patterns are sometimes useful in differentiating the HCM from the phenocopies. If we look at the hazards of the CV events versus the percentage of LGE in the myocardium, the inflection point is 15% and above. However, there are challenges in imaging the left ventricular wall thickness. And the first challenge is the elite athlete. If we look at the distribution of the athletes versus the myocardial thickness, then the white athletes, there are very few athletes who reach the wall thickness of 13 to 14 millimeters. However, the Afro-Caribbean athletes, a significant proportion of them go into the range of the HCM diagnosis. So for the left ventricular wall thickness more than 12 millimeters in this UK study, 4% white athletes were about 12 millimeters and 18% of Afro-Caribbean above left ventricular wall thickness about 12 millimeters. But above wall thickness of 15 millimeters, there were no white athlete and there were 3% of Afro-Caribbean athletes. Second challenge, so the challenge is to differentiate the athlete heart, and we should know that the athletes have got larger LV cavity dimensions. They do not, their E prime, S primes are normal. They have got their E by E primes are normal, and generally the LVH regresses with the detraining of 8 to 12 weeks. However, the second important issue is about the focal HCM or non-contiguous HCM. As you can see here, this 36-year-old lady asymptomatic and an absolutely abnormal ECG. Her 4-chamber, 2-chamber, long axis and short axis are normal. But when you give a contrast and you look at the MRI, you realize there is a focal hypertrophy of only one segment, and it's very easy to miss it if you take standard 4-chamber views or 2-chamber views or the long axis views, which can miss this focal hypertrophy. Third challenge is the poor echo window, as this 55-year-old gentleman, non-hypertensive, extremely obese, who had a syncope while coughing. And this is his transthoracic echo with a very poor echo window. After giving contrast, you have a suspicion of an LV apical aneurysm, and this is his ECG, which looks like hypertrophic cardiomyopathy. But MRI clinches the diagnosis because of his extraordinary spatial resolution, and you can see that there is a significant mid-cavity obstruction and a good LV apical aneurysm, and you have got a transmural LG in the LV aneurysm. The LV aneurysm in HCM is a bad news, because for every 1 centimeter increase in the LV aneurysm, there is an increased chances of sudden cardiac death, stroke, and heart failure. And aneurysms 2 centimeters and more, the stroke risk, the SCD risk for 5 years is almost 9 to 10%. So this is one of the very important risk factors. However, let me come to a very basic issue. How accurate are we in measuring the LV wall thickness? I'll show you this case of 41-year-old gentleman, and you can see that there's an extreme hypertrophy, and what we have measured here is around 31 millimeters, which is supposed to be a very high risk thickness. However, I'll show you a study from UK where 70 HCM experts in 4 major conferences were given 7 random patients with paired echo and CMR data like this to measure the wall thickness. And look at the inter-reader variability. These are the various spaces where all these 70 readers measured the wall thickness in the echoes and the MRIs. And let us look more objectively at the interradial variability. And you can see that as the hypertrophy goes on increasing, there is a great spread of interreader variability of thickness. And these are the paired data sets of the echo and MRI, and the vertical line is the median and the box is the interquartile range, and the whiskers are 1.5 times above and below. And see the spread of measurements both in the echo and MRI equally bad. And that too from the 70 experts. How accurate are we in measuring even the LG quantification? And I will show you one case. This is a case, And what here I have given the instruction to the software to look at mean plus 6 standard deviation image intensity. And I have to just mark what is normal myocardium. And with this, it is giving me a LG percentage of 15%. And then I just change the ROI to another slice for the normal myocardium, and keeping the mean and 6 standard deviation of signal intensity, I get an enhancement of 21%. I change into the second slice and you have got 29%. I change mean to 5 standard deviation, it is 28%. And I use another method of measuring the LG and I get a completely different value. So we are not doing great even in this aspect also. So many experts have gone to this semi-quantitative, looking at the LG, looking at the best, mid, and apical slices, and giving percentage by just looking at qualitatively. Let us look at the symptomatic HCMs. If the patient, now these are the classic slides of the HOCMs, and this is the SAM on the M mode and the thickening of the septum here, and the mid systolic closure of the aortic wall, and the late systolic flutter, and then the dagger shaped LVOT gradient, the claw shaped mid systolic reduction in the ejection, so on and so forth. However, if the patient is symptomatic and if your rest gradient is less than 50 mm, you should do some provocative maneuver and show that the gradient increases. And you can use any of this provocation, especially the exercise is the best. But even you can plan the imaging postprandially and the gradients can go higher. And I will show you a case. This is a 68-year-old lady, HOCM. She used to get pulseless syncope, and she was put an AICD in USA for the pulseless syncope, and her symptoms continued unabated. We looked at her resting echo showed a dynamic LVOT. There is an MR, and the resting PA pressures were normal. We just made her walk in the echo lab up and down and see the amount of MR that has increased just with that amount of exertion, and acute rise in the pH, as you can see here, the TR pressure. So actually this pulseless syncope and the flash edemas were related to an acute exacerbation of the MR. Then here comes the 1 minute. I think I have lost my connection. Yeah. I'm still audible here.
Yes, sir, you are audible.
Yeah, because there was a power outage here, so that's why I thought that I'm not that
You're
I may be out of it. Okay, forget. So evaluating the SAM and LVOTO is precise distribution of septal hypertrophy. You can use transthoracic echo, T, CMR, CCT, anything. Look at the mitral wall subvalvular abnormality, look at the elongated AML, look at the anomalous insertion of papillary muscle directly into the mitral leaflet, look at the anomalous abnormally positioned papillary muscles, look at the accessory muscle bundles in the LVOT, abnormal caudal connections in the LVOT, or even the subaortic membrane. HCM has got interesting heart failure phenotypes also, and I'll show you a case here. He's a 50-year-old HC judge, and known case of HOCM from 1996, and now comes with the progressive fall in ejection fraction, and now he's presented with a dilated heart. So this is the dilated phase of an HCM, and if we look at his MRI, we can see an extensive LG and a lot of replacement fibrosis, and this patient is presenting with a spherical and dilated heart. HCM can also present in the restrictive phase and present like an HEPF, as this 38-year-old gentleman who presents with clinical heart failure. And one can look at the echo, see the ejection fraction looks fine, but look at the biatrial enlargement, a very restrictive mitral flow, severely reduced E prime, S primes, and very high E by E primes. And if we look at the MRIs, we can see that the extracellular volume is high, 28%, and you have got a pattern of LG like an HCM here, but presenting like an HEPF. And then you have got HCM patients presenting with extensive LA electrical and anatomical remodeling, like this patient of 55-year-old gentleman who had an acute chest pain while he was crossing the railway tracks. His troponin was elevated. His ECG was like an HCM, but with atrial fibrillation. And his coronary angio was perfectly normal. But when you look at his MRI, and interestingly, you can see that in the circumflex territory is a transmural MI with a very large microvascular obstruction there, suggesting that there was actually an embolic MI into the circumflex in these patients of HCM with atrial fibrillation. Then there is an interesting pattern of subendocardial LG even in HCM, and this is a 34-year-old male presenting with acute decompensated heart failure, a significant hypertrophy as you can see in the echo and the MRI. But when you look at the LG pattern, obviously this is a pattern of an HCM, but there are areas where it is subendocardial and almost transmural in certain areas. And in HCM, a subendocardial LG is also being recognized as one of the risk factors. And the higher the LG percentage you have, but if the LG pattern is also associated with the subendocardial enhancement, the event-free survival is lower. And then lastly, I'm coming to the imaging biomarkers for the SCD risk. If we look at the hierarchical SCD risk factors as the prior event or the second in line like syncope or the maximal wall thickness, the third in line are the NSVTs, and last in lines are the some of these dynamic LVOTs. I have marked all the imaging biomarkers by the yellow letters, and you can see that maximal wall thickness in adult more than 30 millimeters. In children, Z-score more than 20, LVF less than 50%, apical aneurysm are quite high up in the hierarchy. Lower in the hierarchy is LG on MRI, and lowest in the hierarchy are the dynamic LVOTO, LA dilatation, and dysynchrony. And if we look at the risk, SCD risk score or the calculator available on the net, you would find that it is only the maximal wall thickness, left atrial size, and LVOT gradient has been included. And there is no inclusion of LVF, LV apical aneurysm, or LG in this risk score. And the last thing about the echo, it's very important for monitoring the alcohol septal ablation to confirm the correct septal perforator by injecting into the perforator by the echo contrast. That limits the number of arteries that you inject, limits the ethanol. You can have more precise infarct. You have got less chances of heart blocks and VT, and more profound reduction in the LVOT obstruction. There are phenocopies of HCM, which is my last slide, and you can see this is where the MRI comes in handy along with the clinical features. This is a patient of PRAC2 gene mutation. This is the Fabry's disease, where there's a characteristic mid-myocardial inferolateral LG. This is Danon's, where there's got an extensive LG, but characteristic apical preservation. And then the amyloid, where you have got sometimes even transmural looking LG. So these phenocopies one can differentiate from the HCM, from the clinical data, ECG, family history, and also and the MRI is a great help there. Thank you.
Thank you, Nitin, for an excellent talk as usual. I think the panelists are Dr. Ponde, Dr. Robin, and Dr. Alpa. I think I'll have short comments from them. We have a very short time. So, Dr. Ponde, start with you, actually. Robin.
Excellent talk, Nitin. I just wanted to ask you, is there any correlation between your GLS, which we measure on echo, and the LG values which you get on MRI? I don't think there is, but is there any study to show this? Like if the GLS is very low, then more likely you get a increased LG on MRI?
It's true, but the relation is not very tight. Okay, it's not very tight. Obviously, with the higher fibrosis, the longitudinal function goes down. But probably the late gadolinium, the LG tells about the replacement fibrosis, while the GLS is looking only at the compression of the myocardium. So I think there are two different pathophysiological processes. So that's why there is not a very tight correlation between the two.
Okay.
Dr. Alpa is.
So I would like to make a comment on the extent of scarring that you see on LG and HCM when you're quantifying it. It is true that if you're going to go with any of the AI models or some automated processes, there is a huge variability. But there is always an option where you can draw the highlighted areas with your cursor. So if once you have drawn those manually, then you can get, I think, a pretty standard value for enhancement, because it's more or less like eyeballing, but with eyeballing a accurate percentage may be difficult. But if you draw it, you can get both the extent of mass which is scarred as well as the percentage which is scarred. So that is one point. And the other point is, I would like to know that sometimes adolescent children who come to us with query HCM, all we see is a very hyperdynamic contraction, and maybe the apex is a little bit on the thicker side, but not reaching like 1.3, 1.4, that value. So how do you clinically look at these cases where, we just have a hyperdynamic contraction, but you don't really have a myocardial thickness or any other scarring to, label them as HCM or any other reason for a hyperdynamic contraction?
Yeah, true. So I think from the LG perspective, as I told you, that there is so much of subjectivity there. That's why don't take that 15% as a sacrosanct value in every report. That is what I wanted to say. And second, your comment about the apical hyperdynamic LV. And if you have a ECG which shows deep T inversions and the apex looks slightly hypertrophied and quite hyperdynamic, as you know that there is always this challenge of whether you can label this adolescent boy or girl as apical HCM. Now here actually the AI is very useful, and especially there's a paper from UK where using the biobank data, they had ethnic specific thicknesses at the apex measure to diagnose the apical HCM quite early. Okay, so there was no cutoff. It was more of ethnic based, gender based from the data derived from UK bank. But obviously the UK biobank data would be from the UK population. But I think as we'll have more data from the more diverse ethnic ones and with the AI models, I think this problem may get solved to a great extent. Currently, I think we are just going more with the ECG clinical features and looking at a mild thickening of the septum and a good hyperdynamic LV cavity, which almost gets obliterated during systole.
Okay. Thank you. It was nice talk. Very well covered.
Nitin, I think you think every patient should go for MRI and HCM to get a better quality. Actually,
it really is not required if you have got an extraordinarily good transthoracic echo images, and if you also have a LV opacification contrast, then many times, because the thing that the MRI adds to is the LG quantification. So probably at the SCD risk stratification stage, for refinement, we may need LG, but still LG is lower down in the hierarchy, and we have to use it very carefully. But the another very important thing is, I think, looking at the pedigree and looking at the clinical manifestations, ECG and everything. If we are thinking of a phenocopy, MRI is the way to go.
Nitin, this may sound like a stupid question, but is there a standardized way you do for the Valsalva in this picture?
Not really, but actually, interestingly, we are coming out with some guidelines. Okay, the way we had come out with guidelines for the PFO and Valsalva maneuver, currently we are coming out with some guidelines with a systematically studying an HCM and reporting it by the echo using even the provocative maneuvers.
Thank you. I think we'll end this talk and we'll have a panel discussion. The next talk is the management, and we have Dr. Hashim Ahmed from the Kochi. Actually, he's working with Amrita Institute of Medical Sciences. Been very much interested in this as associate professor in the Amrita Institute, and of course, he has done a lot of pioneering work. And also interested in the hypertrophy of the amyloidosis and advanced cardiac imaging, also deep learning. And we are actually fortunate to have him actually with us, and there's been a lot of basic work done, and a lot of work is going on in Amrita. Not only the medical, but I think surgical work also is going on quite good. So over to you, Hashim, for the medical management of the medical therapy.
Yeah, thank you, sir, for the warm welcome. Am I audible and are my slides visible?
Yes. And I think I request Ash Lokanwala and I think Vishal Desai and Vaibhav Area to panel this chat. I think Ajit Desai could not come. I think there's some issues. Yes, she's there. Yes, she's there.
Yes, good evening, everyone. And I thank the Mumbai CSI organization team for inviting me here, and it's an absolute pleasure to be here. So over the next 20 minutes, my objective would be to provide a snapshot over what are the medical therapeutic options in hypertrophic cardiomyopathy, which medications to choose, and in whom do we start them. So I'll be dividing my talk into the management of obstructive HCM to begin with, and then later on we'll look at the non-obstructive subtype of HCM and look at what the medical therapeutic options are. So to kick off with obstructive HCM, so all of us quite aware what the pathophysiology of obstructive HCM is, and we can see that we have 4 main drug classes available with us today. in terms of first-line agents being beta blockers and calcium channel blockers. We have a second-line agent, which is disopyramide. And of course, we have the newer agents on the block. We have a lot of data since the last 5 years on the new drug class of cardiac myosin inhibitors. So looking at beta blockers, so non-vasodilating beta blockers are preferred. Their negative chronotropy, their negative inotropy, in fact, ameliorates outflow tract obstruction. This is something which all of us have known for decades together. And this, together with decreased myocardial oxygen demand, which these drugs afford, reduces the symptoms in patients with obstructive HCM. So if you look at the right-hand side of the slide, most of the beta blockers which have just been put up have been found of use to manage resting and provoked gradients. And nadolol especially has been a preferred beta blocker, especially in the European HCM centers. They feel that it has the additional membrane stabilizing effect and additional antiarrhythmic property, which affords greater protection in their opinion, and they're quite fond of using nadolol in managing obstructive HCM patients. The efficacy with beta blockers is moderate, and of course, it's important to not to use vasodilating beta blockers such as nebivolol, labetalol, and carvedilol. And the other first-line agent, an obstructive HCM, would be non-dihydropyridine calcium channel blockers in the form of verapamil and diltiazem. And similar to beta blockers, in terms of mechanism, it's the negative chronotropy and the negative inotropy, which in fact leads to a reduction in outflow tract obstruction, and this leads to amelioration of symptoms. A word of caution for diltiazem, because there is a lot of evolving data which seem to suggest that diltiazem can potentially worsen obstruction because of its systemic vasodilatory effect. And that's something I think which is really worth noting when treating patients with non-dihydropyridine calcium channel blockers. The efficacy is modest. And of course, beyond gradient reduction, there's being a benefit in terms of the diastolic function as well. Disopyramide is something which is often added on as a second-line agent. It's a class 1 antiarrhythmic drug. It blocks the cardiomyocyte sodium channels. It reduces sodium-calcium exchange, reduces the intracellular calcium load, and effectively, it's a negative inotrope and therefore relieves outflow tract obstruction. So the target dose, what we usually aim for, is about 400 to 600 milligrams per day. Some of the key characteristics of disopyramide use is that in about 30% of patients, you may end up with a suboptimum response and may trend to lose efficacy over time. The efficacy is modest. And of course, there are some adverse effects in the form of prolonged QTc and anticholinergic effects to keep in mind when using disopyramide in these patients. And often it's considered as a pharmacological bridge to invasive septal reduction therapy strategies, especially when patients don't do well with the first-line therapies such as beta blockers and calcium channel blockers. Now, it's interesting that there was an elegant translation study in 2019, which looked at the electrophysiological and contractile effects of disopyramide in patients with obstructive hypertrophic cardiomyopathy. And there was a very significant editorial comment as well. So in this translational study, the mechanistic effect of disopyramide, in addition to its negative inotropy, it also had a favorable impact on the action potential duration, significantly reduced intracellular diastolic calcium, and hence it had promising antiarrhythmic properties of disopyramide as well. So the essential message of the editorial was that it's an old drug, but it still should form a cornerstone in the management of patients with obstructive HCM because of its negative inotropy and additional favorable electrophysiological profile. More recently, 2025, this is the largest follow-up data of patients with disopyramide and obstructive HCM. So this was published from Mark Sherrod's group from the NYU and Dr. Maron's group from the Leahy group. So essentially, the summary would be that most of these patients who are treated, the average follow-up period for these patients was about 7.2 years. And around 70% of patients continued therapy, and about 30% of patients discontinued therapy because of adverse events or because they did not respond optimally to disopyramide therapy. There was significant reduction in gradients, both resting and provoked, to the tune of 40 to 60%, about 40% for resting gradients and about 60% for provoked gradients. And about 46% of patients showed no residual outflow tract obstruction at the end of follow-up period of about 5 to 7.5 years. And in terms of a safety signal, the drug proved to be very safe, with a rare occurrence of ventricular tachyarrhythmias or ventricular dysfunction. So essentially, summarizing that disopyramide is a safe and effective option even now at relieving heart failure patients with symptomatic obstructive hypertrophic cardiomyopathy. And this remains the largest follow-up study of disopyramide. So this is what we have in our therapeutic armamentarium for obstructive HCM at the moment. And we know these agents afford modest response. Some of them have tolerability issues, and some of them are non-specific in terms of mechanistic, in terms of mechanism. And of course, with refractory symptoms, we must consider the options of septal reduction therapy. It could be alcohol septal ablation or septal myectomy. And of course, 5% of patients may still be symptomatic even after undergoing septal reduction therapy. And most of the outcomes also depend on the expertise of the center in which it is done. So therefore, there is a real unmet need in managing patients with obstructive HCM. And that is where the contemporary understanding of HCM pathophysiology as sarcomeric hyperreactivity has changed the fundamental understanding in charting a new direction in managing patients with obstructive HCM as well as non-obstructive HCM. So targeting the sarcomere is the new approach, and essentially it's a new drug class called cardiac myosin inhibitor, and mavacamten is the first generation agent in that group. So essentially, we know that in the HCM sarcomere, it's hypercontractile, high energy status because there are too many myosin-actin cross bridges, and therefore mavacamten is an allosteric small molecule myosin ATPase inhibitor. So essentially, we are trying to convert a high energy hypercontractile state to a low energy relaxed state by administering this class of drug. This led to the landmark phase 3 randomized control trial called Explorer-HCM, which compared mavacamten with placebo in symptomatic patients with obstructive HCM, NYHA class 2 to 3. And mavacamten met all of the composite functional endpoints, which used a metric of cardiopulmonary exercise testing by demonstrating improvement in peak oxygen consumption and, of course, improvement in NYHA class. It also showed very favorable, it also hit all the secondary endpoints as well in terms of marked reduction in LVOT peak gradients, again, peak oxygen consumption in cardiopulmonary exercise testing, and significant improvement in NYHA functional class. There was a concern that there may be a drop in LV ejection fraction. So the mean drop in LV ejection fraction in this landmark study was about 3.9% with mavacamten, compared to only about 0.1% with placebo. So if you look at the overall safety data, approximately 7 patients in this trial at the end of 30 weeks had an ejection fraction of less than 50% secondary to the drug. 3 of these patients had an asymptomatic decline. The good news is that all of these patients had reversal of these impaired ejection fraction to normal levels after cessation of the drug. So what happened to these patients in the long term? We have data for that as well. So the long-term extension arm of the landmark trial clearly showed that the initial benefit seen over 30 weeks continued to persist in terms of reduction in the LVOT gradients, no significant safety signals from LV ejection fraction, fall in LV ejection fraction. There was a trend towards lower left atrial volume indices, and of course, the NT-proBNP remained low in a sustained manner. There was significant improvement in NYHA functional class, but importantly, it's also very important to note that approximately 25 to 30% of patients did not have any significant improvement in NYHA functional class. And if you look at the long-term extension study, which is about 252 weeks, you can see that approximately 13 patients over time developed LV ejection fraction less than 50%. 8 of these patients resumed treatment after the LV ejection fraction improved after stopping the drug and going on to a lower dose, and 5 patients discontinued study. This is data from the long-term extension arm. So naturally, the question is, what would happen if this drug was used in much more symptomatic patients? So essentially, you are looking at patients who are eligible for septal reduction therapy. So this is a trial which looked at that, which is called the VALOR HCM study, which looked at patients who have been referred for septal reduction therapy within the last 12 months, and they were on maximum background therapy, and patients were compared in terms of mavacamten versus placebo. So the primary composite endpoint was at the end of week 16, was there a decision to proceed with septal reduction therapy, or was the patient still considered guideline eligible for septal reduction therapy? And as you can see, over 16 weeks, there was a significant reduction in the post-exercise LVOT gradient as compared to the baseline. And this is, of course, compared to placebo at the end of 16 weeks. And as you can see, at the end of 16 weeks, only 18% of patients in the mavacamten arm continued to be guideline eligible for septal reduction therapy. But I think it's also, to be fair, it's also important to note that approximately 37% of patients did not experience any significant improvement in NYHA class. And you can see almost 63% of patients experience significant reduction in symptoms and therefore an improvement in their NYHA class. So fast forward the same trial. So at 128 weeks, you could see that only about 16% of patients still remained guideline eligible for septal reduction therapy. And you can see that 95 patients out of a total of 95 patients out of 108, they transitioned to commercial mavacamten, and this is what out of choice at the end of the trial. And significant improvement in NYHA class, even at the end of 128 weeks. And importantly, it's also important to see both sides of the story. Approximately 20% of patients did not show significant improvement in terms of functional class while on mavacamten. And you could see that in terms of safety signal, 13.8% of patients developed an ejection fraction of less than 50%, although in real-world studies, this rate is much lower, to the tune of only 2 to 3%. Aficamten is a second-generation cardiac myosin inhibitor. It has a shorter half-life compared to mavacamten. It has a wider therapeutic window as a result, and it's not influenced by cytochrome P450 isoenzyme inducers or inhibitors, and has some distinct advantages over mavacamten. And the data shows that it is fairly as equally efficacious as mavacamten in reducing LVOT gradients in patients with severe obstructive HCM. So how do we really contextualize cardiac myosin inhibitors in therapy now that it has come into the guidelines? So is it first line? We don't have data yet. There are studies recruiting patients to address this specific question, but we don't have the data yet. In terms of long-term efficacy and safety, we have data which is now 5 years out, but then it's not a sprint, it's a marathon, it's a new drug class. We really need to see much longer safety data, in fact, to really embrace this drug in routine clinical practice. Does it have a disease-modifying role? So there was an interesting cardiac MRI sub-study of the Explorer HCM study, which showed that patients on mavacamten were demonstrating a trend towards LV mass regression. So that was an interesting finding, but at the moment, it's just an exploratory finding, and we need much more well-designed, properly powered prospective studies to identify that. Does it have a role in non-obstructive HCM? Not at the moment. We have a trial which is coming, Odyssey HCM, which has finished recruitment, which will probably answer that question. So at the moment, it's an add-on to beta blockade or calcium channel blocker or disopyramide as an alternative or to delay septal reduction therapy. The ESC gives it a class 2A recommendation as an addition to beta blocker therapy and a class 2A level B evidence as monotherapy. And the transatlantic guidelines, the ACC-AHA, gives it a class 1B recommendation to initiate mavacamten in addition to beta blockers or calcium channel blockers in severe obstructive HCM patients. Now, just a word about non-obstructive HCM. It's an entirely different beast in terms of treatment. And these patients often present with dyspnea, angina, common symptoms, which may be due to diastolic dysfunction or macrovascular ischemia. And of course, beta blockade and calcium channel blockers have been tried. There is some evolving data that aggressive use of beta blockers in these patients may not be effective, in fact, may be counterproductive in terms of worsening diastolic dysfunction. And that has been documented by a reduction in the peak oxygen consumption and chronotropic incompetence. And in such cases, calcium channel blockers may be preferable in the non-obstructive HCM subset. And it has a calcium channel blockers have and beta blockers have a class 2A recommendation level of evidence C across the board, according to the recent ESC guidelines. So not all is lost in non-obstructive HCM. We have interesting data that SGLT2 inhibitors have had significant impact on all-cause mortality, all-cause hospitalizations, and cardiovascular symptoms. This is not a prospective study. This is an electronic health record study from the Marans Group, which is published in 2024, which sort of is consistent with the experience with heart failure with SGLT2 inhibitors. So more well-designed prospective studies are needed to understand how these drugs help, especially in the HCM subset. But I'm sure most of us have already started to use this in the non-obstructive HCM subset who come with the clinical syndrome of heart failure. There's another drug which is in the horizon, recently published data. This is called ninarafaxtat, which is a mitotrope, which is an inhibitor of a 3-cat enzyme, which is one of the enzymes in the fatty acid oxidation chain. And so this was a phase 2 study which demonstrated safety. This was not powered to look at efficacy. And of course, this study laid the ground for the phase 3 study, which has already started enrolling patients. This, in fact, aims at altering myocardial energetics to correct the altered myocardial energetics, which is often found in patients with non-obstructive HCM. A quick word about the progressive end-stage disease in HCM. Approximately 10 to 15% of patients, they develop severe fibrosis and diastolic function worsening. And 1/3 of these patients may go into a phase of severe systolic dysfunction and a restrictive physiology. So essentially, we were looking at the burnt out phase of the disease, in which case other drugs which have robust evidence base in managing patients with heart failure with reduced ejection fraction will come into play in managing these patients once they transition to a burnt out phase and a subsequent drop in LV ejection fraction. So it's not, gene therapy is not science fiction anymore. And so in patients with the hypertrophic cardiomyopathy with a genetic basis being myosin binding protein C3, the first gene therapy trial started in 2023, and this was led by Dr. Milind Desai's group from the Cleveland Clinic. And the organization is Tenaya Therapeutics. So they dosed the first HCM patient in a gene therapy trial, and the trial is called MyPeak-1. And the early results were published just a few months ago, where it was safely tolerated. The vector which was used for the gene therapy, the vector DNA was found in the heart, reliably, and which also there was reliable transgene RNA expression in these patients, and with increasing levels of mRNA levels as well. And all of this, leading to the fact that there was sufficient expression of myosin binding protein levels in these patients. So this is very early data, and this is something which a lot of us in the field are looking forward to. To summarize, the medical therapy in hypertrophic cardiomyopathy has undergone a significant change in terms of landscape. Now we have new agents, cardiac myosin inhibitors, with a rapidly evolving evidence base. And this is the first new agent that we have had included in the guidelines in the last 60 years for the management of obstructive HCM. And of course, there are phase 2 trials with the metabolic modulators, as I just showed, and we need much more data, in fact, from phase 3 trials to understand whether these drugs will have a positive impact on patients with HCM, especially the non-obstructive HCM subset. And of course, we have the traditional established therapies, beta blockers and calcium channel blockers. And as you saw, disopyramide, which has robust foundational evidence and which will continue to be a foundational element in managing patients in our clinical practice. And of course, much more advanced therapies are on the horizon, such as gene therapy, and we've seen early evidence of that as well. Thank you for your patient listening.
Yash Lokhandwala. So that was a wonderful bird's eye view, and you really covered everything. And, I had a couple of questions. One is, I'll come to my second question first, but the newer therapies which you keep talking about, especially the gene therapy. Now, you also showed this trial of the Cleveland Clinic. Mm-hmm. Now, do you think it will translate into reality?
I think the honest answer would be it's too early to say, because there are challenges in terms of not just efficacy, there are challenges in terms of administering the vector, which is currently AAV, adeno-associated virus, the immune challenges, the immune suppression challenges which are associated with continuing or dosing patients with AAV vectors. So it's not just a question from the standpoint of efficacy, it's also a question from the standpoint of safety. It's too early to say. I think all that they've managed to publish so far is that they've managed to document a reliable expression of mRNA and the protein which is deficient. In this case, it's myosin binding protein C3. So it's too early to say, to be very honest with you. So I think we have a long way to go before even beginning to understand how it will translate into clinical care.
And a question which was also raised in the chat box, that how does one decide in non-obstructive and in obstructive, if bradycardia is not limiting us, how high to go on the dose of calcium channel verapamil or beta blocker or disopyramide? How high to go on the dose? How does one decide whether what dose is enough? Let's say non-obstructive, for example, because the common drug we use here at least is verapamil. At least I use in non-obstructive.
Yep. So if it's non-obstructive, of course, disopyramide is definitely not a choice. I think it'll be a choice between beta blockers and verapamil. So if you look at the evolving data of the last half a decade or so, there is a very vocal group, who seem to recommend that using beta blockers in an aggressive manner in non-obstructive HCM patients with severe diastolic function can be rather counterproductive. Especially adding on chronotropic incompetence to a patient with severe diastolic dysfunction seems to be very counterproductive. So in that scenario, the current consensus, it's not part of guideline, but the current consensus is that if you have patients with non-obstructive HCM and you have to choose between a beta blocker and verapamil, the choice seems to be towards verapamil because in addition to a little bit of rate control, it also seems to have a significant beneficial effect on diastolic dysfunction, which beta blockers do not have. And of course, there is this evolving evidence with SGLT2 inhibitors in terms of improving diastolic dysfunction in patients with non-obstructive HCM as well.
And in obstructive HCM, the typical what I see and what I also practice is disopyramide 100 milligram thrice a day and leave it at that. Now, how does one decide how much dose to go to? If you're, for example, if your outflow gradient is not falling significantly, you step up on the dose, or if the patient is symptomatically better, forget about the gradients. What is the way to go?
Yeah, so that's a very important question. So our practice at our center is very similar, sir, to what you've just described. So we tend to, leave it about 100 milligrams, thrice a day, and see. So we go by two factors. I mean, two elements. One is the symptom of the patient, and of course the gradients which you can actually demonstrate on the echo. So if you're achieving about, let's say, 30 to 40% reduction in gradients, which is accompanied by symptom reduction and an increase in the quality of life, we would leave it there. Because we have seen that higher doses sometimes when patients use it for a longer time is associated with some adverse events which leads to discontinuation in terms of therapy. So I would say and that's what the data shows as well from the paper which I shared. So if it's about 30 to 45% reduction from baseline gradients, quality of life has improved, then I think it would be a fair choice to leave it where it is. If it's not, then I think it's an informed decision-making discussion with the patient and then to go up on the dose to about 450 to 600 per day, yes.
And those with mild obstruction or only provocable obstruction, where we tend to more use beta blockers, especially if they have some atrial arrhythmias or some PVCs, we like beta blockers. I've been using atenolol because I thought it is one which more potent, negative inotropy compared to other beta blockers. And that's what I was taught from my cardiology days, atenolol. So is there any role today for atenolol in HCM?
Yes, sir. So, sir, the question is regarding evidence-based. Unfortunately, not. The evidence-based that we have for beta blocker was a randomized controlled trial with metoprolol, which was published 2 to 3 years ago in JACC. So in terms of evidence, but I suppose in terms of clinical use, it's a tried and tested molecule, atenolol, and so in terms of achieving the purpose for which we are giving it, and if we can demonstrate significant reduction in gradients or blunting, an aggressive increase in gradients, especially exercise-induced gradients, I think it would be a fair choice. We have started to use propranolol quite significantly now. So we don't have access to nadolol. In terms of pediatric HCM, so we have shifted largely to propranolol because of its inherent membrane stabilizing effect, which is also there in nadolol. So propranolol seems to be making a comeback in managing patients with obstructive HCM. Especially, we have some data with the pediatric HCM subgroup.
Hashim, are you started using SGLT inhibitors in this protocol?
Yes, quite liberally. So in patients with non-obstructive HCM patients with diastolic dysfunction and with the HFpEF phenotype, we have started using SGLT2 inhibitors. In fact, one of my colleagues, Dr. Muthaiya Subramanian, who works from Dr. Narasimhan's group from Hyderabad, so he had done a very elegant study on monitoring the pattern of diastolic dysfunction pre and post SGLT2 inhibitors and non-obstructive HCM. He presented this at the European Society of Cardiology. In fact, he won the investigator award for the paper as well. So clearly, I think the study demonstrated that there seems to be a trend in improvement in diastolic dysfunction in patients who are started on SGLT2 inhibitors. And this is the non-obstructive HCM subset. We haven't had large trials to look at this, but the clinical experience seems to be quite positive.
So just a quick question, Dr. Vaibhav Dedia here, Dr. Ishan, you actually have covered almost everything. What would be your pharmacotherapy of choice in asymptomatic patients with non-obstructive hypertrophic cardiomyopathy? Would you treat them, or would you just closely follow them up for symptoms?
Yeah, so I think that's a very important question. So if they are asymptomatic, and if it's just non-obstructive HCM, asymptomatic, and the patient does not have additional risk markers of SCD in terms of imaging, clinical history, etc. I think the trend has now been not to start them on any medications. But let's say if it's a non-obstructive HCM who is not symptomatic, but on the other hand, seems to have some red flags in terms of an increased SCD risk. Let's say the thickness is quite extensive, or there seems to be significant late gadolinium enhancement, not to the tune that you would implant an ICD, but some significant LGE or other risk markers, then a baseline low-dose beta blockade seems to be the practice, yes.
I think close follow-up will be required in case.
Absolutely.
Can I
Yes.
extend that question to obstructive HOCMs? Also on exercises testing negative, as in asymptomatic, truly objectively asymptomatic, because we do see a whole lot of HCM people who get diagnosed basically on imaging modalities. They don't necessarily have symptoms.
Yep.
So do you pharmacologically treat them at all? And if so, is there any evidence for it?
So currently, there's not much high-quality evidence to, in fact, treat patients with, a baseline beta blocker, obstructive HCM, absolutely asymptomatic. And I think the key word here is demonstrably, objectively,
Absolutely.
assessed.
Because I have such patients
Yes.
whom I'm just not even advocating SRT for that matter.
Absolutely. So
That's a class 3 indication, right? Out there.
Yes.
So I think we should end here. I think we should start the next speaker.
Yeah, I think I'll just quickly respond to the question. I think practically we have ended up actually starting these patients on low background beta blockade. But honestly, I don't think we would have enough quality evidence to support that practice.
Okay, thank you. Excellent.
Thank you, sir. Thank you, Hashim, for a very excellent talk from Kochi. And I think Praful is also in Kochi today. The next talk is the septal ablation by Dr. Suresh Vijayan. And chair this session, I think we have Praful and Rahul Gupta and Sushant Patel. Over to you, Suresh. Is actually a cardiologist at my colleague at Lilavati Hospital. He was in pioneer work in the septal, one of the longest series. He was the first to implant the ICD, and he will be. We have a great experience in septal ablation, especially HOCM, longer series of more than 500 people patient. So I think over to you, Suresh.
Thank you very much, Ramesh, for the invite to come and talk to you of septal ablation for hypertrophic cardiomyopathy. So just a brief introduction about the procedure. It's a very simple procedure to do, actually. It amounts to injecting a small amount of absolute alcohol, first described by Professor Ulrich Sigwart way back in 1996, for which he received a lot of flack from people like Celia Oakley and John Godwin. But basically, it is to treat and try and reduce the septal thickness in a patient with significant, by which I mean more than 50 millimeter gradient at rest or provocative outflow gradient. And the amount of alcohol to be injected has progressively gone down from 5 ml to begin with now to 1 to 3 ml. And is currently a class 1 indication along with surgical septal myomectomy for management of drug refractory symptoms in patients with hypertrophic obstructive cardiomyopathy. It's a rather busy slide. I won't go through the details of it, except concentrate on a few things which matter, because I do get a lot of people talking to me about having done a septal ablation, not have a good result. There's been spillage of alcohol into the LAD. And key things that I try and highlight is, one, when you have your balloon in the septal artery, inflate the balloon, obstruct the septal artery, inject a dye into your main coronary, and see that the dye does not cross the balloon, so that your fit of the balloon to the septal artery is perfect. That will prevent regurgitation of alcohol when it's ejected. Second thing is, when you're doing that, inject alcohol very slowly, less than 1 millimeter per minute. Leave the balloon up for at least 5 minutes after finishing your alcohol injection. And then the next thing, before you want to deflate the balloon, inject saline through the lumen of your balloon to wash out any alcohol that may be lying inside the lumen of your balloon. And then put a wire through that balloon before you deflate the balloon.
Recording in progress.
Hello? Sorry. Okay, wire through the balloon
sir,
before you
please
deflate
continue,
the
sir.
balloon. And the fourth thing to do really is, just before you're deflating the balloon, to inject dye again into your coronary arteries. Make sure that there's a column of dye in the proximal LAD when you're deflating the balloon. So if there is by it, any alcohol lying around will go downstream into the septal perforator. And that should, in my opinion, reduce the chances of you getting dye going down the septal artery, or going down the LAD, causing an infarct and all kinds of problems, for which then you have very little to do for these patients. So keep balloon up for 5 minutes. Aim of the procedure is to get 0 gradient at rest and at provocation. Of course, the septal placing wire in all the time, so that you are treating heart blocks with the curve. Monitor these patients for at least 3 to 4 days in the ICU with a pacing wire inside, and then watch and see how the patients develop. So that would be kind of a summary of what. I'll just show you a case. Okay, you can see that large septal perforator there, really drain pipe for a septal perforator. I put in a 2.5 millimeter balloon down there for that one. That's the LV gram. You can see very thickened papillary muscles here. That's the gradient you measure with the pigtail in the LV apex and the guiding catheter in the aorta. A good enough gradient at the time of you starting the procedure. This is the balloon into the septal artery with a wire in there. And this is the deflated balloon. Next is this balloon's inflated, and you take a picture. You make sure that there is no dye going down the septal perforator, making sure that the seal of your balloon is perfect, and then leave that balloon inflated while doing all your other studies. After taking the wire out, I would inject. This is a still image. You can see the septum quite clearly thickened at the base, and that's a highlighted septum. I have, contrary to a lot of people, still keep on using agitated saline, because that's what I was trained for, and that's what I've done all the time. This is the gradient before. You can see this Brockenbury effect quite nicely, and a gradient across the area, and that's post-ablation. ECGs change, and the gradient is hardly 5 millimeters at rest. So you have successfully completed a septal ablation procedure. Sorry. Yeah. And that's the picture. You can see that septal artery there is totally occluded. Successful completion of it. What would you do next? Yeah, here it is now. You can also do an echo during the procedure or just after the procedure. The upper panel is a classical dagger-shaped gradient that you can see. And here, post-ablation, the gradient is actually gone or not. So you can use that also as a way of confirming what's happening. So where do we go from here? That's post-ablation angiogram. LV angiogram showing you that the function, the dilatation of the ventricle is not constricted, giving you a good idea. This is just another picture from one of my publications with a pacing wire in situ. Now I actually don't leave the pacing wire inside the RV. I leave it in the IVC and promptly go in and do that. Again, the same thing. That's your interventricular septum that you are interested in, and that's a highlighted one with agitated saline, and that's procedure. The artery which was here is blocked off. So you have a successful procedure here. Now, this is something which is very gratifying. This is a picture of a patient with hypertrophic cardiomyopathy, and this is a picture of the same patient about 8-9 months after having done the ablation. You can see the nice punched out reduction in the interventricular septum, leading to an increase in LVR flow tract. And this is actually a very good example. You see lots of it. I used to do thallium scans first to look at all these things, but now I don't. I just go by echo, and that's good enough to see that the patients continue to do very well. So where does it leave me in terms of what I've been doing? I started doing ablations in 1997 when I was at Kambala Hill, and this is my data till December last year. Total number of patients that I've done is 867. I must add that I've traveled for this procedure across India and across Southeast Asia. So about the actual follow-up that I have is only for 653 patients over the period of time. Predominant male patients with age range from 27 to 68. I've actually never done any procedure patient below the age of 20. The mean resting gradient for the bulk majority was 70 with a range from 50 to 120. I usually don't touch anything below 50 at all. And the procedural success in terms of significant reduction or abolition of gradient at the time of the procedure is 98%, which is quite satisfying because you do it pretty well, and you make it sure that you're very pedantic. My procedure is I just don't deviate from what I set out to do. And all the things that I mentioned earlier, I do to make sure that there are no complications. The mortality, yes, there are 2 patients have died within 30 days of the procedure. One actually did not get up from sleep about 3 weeks after the procedure. Another one who actually consulted me went home a few days later, crashed at home with acute LVF and could not be revived. So those are 2 mortalities I have. Number of pacemaker implantations plus minus defibrillator, 9% of my patients actually would require either a pacemaker or defibrillator or both. And the range of these patients could be while I've done the procedure and before discharge. If I see intermittent twist on heart block occurring on day 4, day 5, I'd be inclined to put a pacemaker and send them home, or up to 2 years following the procedure. I've recently had some patients who've come to me post-septal myomectomy, surgical, 4 years, 5 years down the line, where they've now required a pacemaker to put in. So clearly, the pacemaker incidence is about 9%. In terms of surgery, I think it's about 3 to 4%. How about redo patients? About 12 patients over the years I've had to redo, and they usually be the ones where I was not very sure whether I should hit the first septal perforator, second perforator, and I've elected to do the first perforator. The gradient hasn't gone down much, and a few months later, I've gone in and done the second perforator. So those are about 12 patients of that. But interestingly, in the last 2 years, I've seen 7 patients post-septal myomectomy who've come back with a residual gradient that required an ablation to be done. So that's the kind of data that is there available today. I'm sure these patients who have come back have probably early experiences of our surgeons who have operated. One patient came to me about 8 years after his septal myomectomy with a gradient, and the echo shows that the gradient has been there for some time. So that's the kind of data that is there. Pretty gratifying to do the procedure. I think it's very simple and elegant to do it, provided you watch out for complications and then actually follow up your patients carefully. I regret because I can't actually give data for the whole patient. They're all over spread out, and after a year, it's so difficult to trace out any follow-up being the kind of problems we have for our patients. So where do we stand as far as septal reduction therapy? I know my talk is going to be followed by a surgeon who's going to talk about myomectomy, but clearly, what do I do? Clearly, medical refractory symptoms to beta blockers, calcium channel blockers, disopyramide, and I, of course, cardiac myosin inhibitors. If they are there, then you have to refer to a high volume center. This is Shriyari Naidu's algorithm, which I actually follow quite well. Refer to a high volume, because I think volume decides how the results are going to be for these procedures. So alcohol septal ablation volume at least 10 per year, and septal myocardial myomectomy volume of at least 40 per year are centers where you have a high volume which you could do that. Clearly, when should we do septal ablation? When we should do myomectomy? I would just concentrate on the thing on the left, a sigmoid basal septal hypertrophy, a very adequate septal artery, and more importantly, no need for any other cardiac procedure. I would offer them septal ablation. Clearly, if there is concomitant mitral valve disease, concomitant coronary artery disease, aberrant papillary muscles, a subaortic membrane, then I think they would be best treated by surgical myomectomy. I've done hybrid procedures where patients have had coronary artery disease and have come to me, and the coronary artery disease was picked up at the time of angiogram rather than during pre-angio assessment. And a couple of them I've actually just done LAD angioplasty, and the symptoms have disappeared and are now well controlled with a small dose of beta blocker. So I really haven't done septal ablation for those patients. So that's kind of sums up what I've been doing over the last 27 years. And thank you very much for your attention. And I'm open to questions. Thank you.
I think you have a large series of more than 800 patients. I think, as you said, the surgical cases of myectomy has come to you again.
Yeah,
How
only
often the septal ablation patient go to surgeon back?
I won't know. I just don't know.
I think Praful is comments, and there is
Yes.
actually Rahul Gupta. And
Excellent talk, Suresh, as always. Yeah. And you covered pretty much everything, and you have such a vast experience. Now, this thing about the end point of the gradients, meaning you do accept you go on injecting alcohol till you get a zero gradient, because it's been our policy, at least, I don't know, because we are very afraid about the causing a problem related to alcohol, and to keep the alcohol down. We don't care about the patients coming back again with a residual gradient, because by and large, even if the gradients haven't dropped completely, a 50% reduction in gradient is good enough. So having said that, what's your endpoint of alcohol? Meaning in terms of, do you get, if you get, because very often right bundle branch blocks do occur. So do you yet not bother about them and yet go chase the gradient? Because that is something, if you can, because there's a lot of interventional audience also, besides, of course, the non-CSI.
I think that's a very good question, Prabhu. I think my top limit for alcohol is 3 ml. I will not inject more than 3 ml into the artery. Then I would leave.
Yeah, so at that point in time,
yeah.
at that point in time, if you haven't got a zero gradient, you're fine. But you wouldn't now go beyond 3 ml. Okay. So the endpoint becomes the maximum amount of alcohol that you inject. And what if you get, during the course of these injections, if you get a right bundle branch block, do you stop? Are you worried about that CHB, or how? How do you go about
I don't worry about the right bundle branch, but moment if I see a CHB during alcohol, I stop that. I wait for it. Generally, it passes off. It's a transient thing that disappears and doesn't come back. So I'm happy with that. But yes, if it persists, then I would not inject any more alcohol, because I know this patient will require a pacemaker. And once he is in complete heart block, measurement of the gradient becomes very difficult, because the whole morphology has changed from sinus rhythm to now a complete heart block. So whatever you can measure may not necessarily be the correct gradient in that patient.
Okay. Okay. So the message out here, meaning I was trying to say that, meaning a lot of people, now that alcohol reduction has happened, you come back again, don't consider it to be a complication or a failure of the procedure. Very often over the year, the gradients keep dropping. Again, because I've done most of my procedures at university hospitals, and we don't necessarily charge for a redo. So we are okay. So what message generally we try and give is that just aim for a 50% reduction. In fact, we have seen the gradients go up also pre-discharge. And then, over the period of time, they again start going down, and you get those nice kind of concavity in that basal area that you showed in your slide. Yeah.
Yeah, I
So
think
that was
yes, you
one
do.
thing.
Yeah.
The other thing
What
that
I would go ahead.
Go ahead. How often have you abandoned the procedure because, based on the MCE, the myocardial contrast echocardiography, for which you use agitated saline, because that's great. I would also love to start doing that, because of late, there is a big debate about what kind of a contrast to use, given that Levovist is not available anymore. So I was asking you, how often do you see the collateral, meaning collateral damage, potential collateral damage?
I think what I've actually seen, even with agitated saline, is that if your base right ventricular wall starts lighting up even with agitation. That tells you there are collaterals, alcohol is going to go there. I would stop. I would not proceed. And that's an inappropriate case for alcohol septal ablation. That's one. The thing is, talking about a redo procedure, if you have occluded the septal artery completely, and the patient still has 6 months down the line a residual gradient, which is significant, I have landed up hitting the second septal perforator because the first septal perforator is not there, it's blocked off. Now, if it's open, then you can go and re-occlude it. But otherwise, we'll end up putting a second one. Now, in that scenario, I worry about the size of infarct I'm giving that patient in the septal region, and that is a genuine concern. No doubt about that. So that's something I would keep. If I need to do it, I would do it. I would absolutely have no problem with it. And as I showed, that many patients where I've gone in and done it. But most of them have actually gone and created a different septal perforator.
Okay.
Good.
Yeah,
Rahul,
so
any
because we
comment
do
or
go
any
for
free?
branches also, branches of septal perforator. We no longer knock out the entire septal perforator. We just do the branches, and even if those are good enough, we are okay with it. Yeah.
Yeah,
So
I
Dr.
did
Rahul,
that, and
Yeah.
I think I stopped doing that now because what I found is in those patients by selectivity down one of the branches to it, a lot of them came back for redos.
okay.
Sir,
So I gone back to doing the main septal perforator again.
Okay, what about the washout of saline? Agitated saline, how long does it last there? And
It washes
suppose
out.
we have to inject again into another septal perforator, does it confuse the echocardiographer is what I'm trying to
It does not. It actually washes. I mean, one of the reasons why I like using saline is it washes out very, very quickly as compared to
The contrast.
ultrasound dye, which stays in for a long time and you need to keep on flushing to get it out of it. So yes,
Yeah,
Kapil,
Rahul
one of the
may have some
advantages.
questions. Rahul, go ahead.
I have No, I think excellent presentation. There was just a question I think Dr. Jawale has asked that is there any role of coils instead of alcohol? That was a question I think which
any
I found in the chat.
I think people have put a lot of stuff down septal arteries. Oils have gone in, carbon particles have gone in, glues have gone in. So all kinds of things have been used to block the septal perforator. But alcohol has been widely used, probably the most popular of all the materials you can. And the reasons why alternative substances were put down was the fear of alcohol spilling out or alcohol going downstream.
Yeah, if I may
I
answer
don't.
that
For me, most
question,
of it
there
is
is
alcohol.
very few studies of coil and the evidence base is not as much. And again, the follow-up studies aren't great because we feel that just ischemic occlusion is not good enough. You've got to put alcohol there to denature the proteins out there and actually cause necrosis because you might
Yes.
get collateralization and meaning the area would get supplied again. So it's not
See,
good
one of
enough.
the reasons
Coils.
why I say keep the artery occluded for 5 minutes after injection is to allow that alcohol to work on the myocardium. That is
Absolutely.
what causes the necrosis. That is what causes fibrosis later on, and the septum starts to shrink. Initially, after you do the procedure, next day there's going to be a lot of inflammation in that area of the septum. The septal thickness may actually go up a little bit. The gradient may actually look worse 24 hours after having done the procedure. But as time goes by and then the swelling subsides, fibrosis sets in, contractions every 6 months, you
Patil
actually
wants to
see
say
the kind
something.
of septum.
Sushan Patil, you have any comment? Yes.
I have one question. In your practice, did you ever have spillage of alcohol in the LED, and what was your experience, if at all you had, and how did you deal
That's what
with
I
it?
have actually been very, very, very strict on how I do that procedure. And what I outlined to you when I first talked about the procedure is what I
Yes.
have followed consistently. But every time I've been asked about a problem that's occurred with it, it's always been because somewhere along the line, one of these steps has missed. I've been very, very fortunate, partly because I'm very a stickler when I do this procedure, to prevent that
You must have come
one thing
across these
which can.
cases which
Yes, I've come
must
across
have been
many
discussed
because
with you,
I've
and how did
traveled
they
enough
manage it?
and people have done it. When it occurs, you have a problem. What I suggest, and usually I am told 24 hours after the procedure, so you can't do anything at that time. It's all gone. It's at that time it happens, just take a saline injection and just keep on flushing that LED and hope that a lot of. Unfortunately, the amount of alcohol that will spill is going to be less unless you have injected a lot of alcohol. And
So I
that's been one of
think,
my concerns why I actually don't go beyond.
I think last talk is by surgeon. I think
Yes.
Vijay actually is from Delhi Gangaram Hospital, and he's going to talk the septal myectomy, which is actually will be discussed. So he has been trained in UK and USA, mainly in UK, and presently working at the Gangaram Hospital. So over to you, Sujay. And the panelist for that, actually, Dr. Sanjay Vichare is with us, actually. Dr. Suresh Joshi is not here, and I think Kaushal is also busy with some emergency. So Sanjay Vichare will be the panelist. And over to you. The last talk of this, actually, I think we should finish it.
Good evening, Dr. Dangar. Thank you very much for your patience and the invitation. I would start with this little slide, which shows a normal myocyte in the beginning, hypertrophic cardiomyopathy in the second, and an apical cardiomyopathy in the third. And it actually shows that there is a reduced space for the anterior mitral leaflet between the anterior mitral leaflet and the septum. And that is the problem. And we know that abnormal position and attachments of the anterior papillary muscle are the reason why the anterior mitral leaflet comes into the view of the left ventricular outflow tract. So we do talk a lot about Venturi effects, but it really is something that needs to be discussed once again. Genetics has been done, and a lot of things have been talked, but most of our patients would get worse while on medical management, generally associated with a tachycardia, often atrial fibrillation. If that happens, then patients suddenly demand an operation and get going with the surgical treatment. So we have seen better pictures than this. On the MRI, I would often ask for an MRI before planning a surgical procedure, because I want to not only see the mitral regurgitation and confirm the mechanism of an eccentric leak, but also I want to see the exact location where the dephasing jet starts on the MRI. I do also an echo in the apical fourth chamber and measure the length exactly at the same point, because that will be denoting the extent of the surgical myectomy. For surgeons, it's very important because to know the relation of the anterior mitral leaflet, the septum, and the sternum, because many of us still come out of the medical school thinking that the septum would somehow be in a vertical orientation or slightly oblique. But if you look at the anterior mitral leaflet on this view, the anterior mitral leaflet is moving between the posterior wall and the anterior wall, and that's where the septum is. So the septum is literally parallel to the sternum. And that is something that need not be forgotten by people who are operating on the septum. This is the three-chamber view of the on the CMR, and this is the view where we measure the length and thickness of resection from the aortic valve, and we have calipers to measure the resection adequacy length of resection adequacy during the operation. So symptoms refractory to medical treatment, gradients more than 50 at rest or on provocation. And majority of the times patients have associated mitral regurgitation. There's a dynamic mitral regurgitation, which is often grade 2 or grade 3 out of 4 at the time of presentation. And I'll talk about mitral regurgitation in a moment. I think we've covered all of that. These are beautiful surgical slides, which thankfully have been provided by Dr. Shaf to me. And this is the surgeon's view. The dotted line is on the ascending aorta. We can see the right coronary artery, the right atrial appendage, which is coming close to the right coronary artery. The pulmonary artery in this schema, the right ventricular outflow tract, is a little towards the right side. It should be a little to the left, but that's a fair deal. This is a representative view of what we see during the operation. After doing an aortotomy just above the sinotubular junction, the aortic valve comes into view after we place the sutures to retract the aortic wall, and the aortic valve is now visible. I have started placing very fine suture on the non-coronary leaflet, which is towards the right side of the field. That is the non-coronary leaflet. I put a suture onto the non-coronary leaflet to retract it, because that leaflet is often at risk from the knife when it is coming out of the left ventricular outflow tract. So to avoid damage to the non-coronary leaflet of the aortic valve, I put sutures to retract it out of the valve. And then with a combination of suckers and retractors, we can display the anatomy and carry out an examination and resection. What Dr. Schaaf suggests, and has been done by others as well, there's a lot of followers, is that you depress the posterior elements, the mitral valve leaflet, using a sucker, and carry out a gentle dissection dotted along the line 1 in the basal septum. Once we have done this resection, the field opens out a little, and then we are able to see a little deeper, and then able to go up to 4.5 or even 5 centimeters from the aortic valve to carry out a complete resection. The depression of the anterior wall with a swab stick, which is held on the front of the heart, often helps us to visualize the distal part of the resection. And once the distal part of resection is completed, you can see an enlarged left ventricular outflow tract. And thereafter, we come to the more important part of the operation, and that is release of papillary muscles, which are attached to the body of the anterior mitral leaflet. These are abnormal papillary muscles emanating from the interventricular septum, attaching to the middle of the anterior mitral leaflet. This is not very common, this papillary muscle, but at times it is there, and this has to be resected completely. In addition, there are chordae which are pulling the anterior mitral leaflet towards the septum. These abnormal attachments, they can be at the level of the leaflet, the chordae, or the anterior papillary muscle. So once we have taken down these chordal structures, the left ventricular outflow tract starts looking normal. And thereafter, the anterior papillary muscle should be separated from the interventricular septum by about a centimeter or a centimeter and a half, depending on the level of visibility that we get. We cannot get very aggressive with this because the view is very limited, and the risk of injuring papillary muscles or the chordae is ever present. So large centers have carried out large number of cases, and presently the mortality of hypertrophic cardiomyopathy is less than 1%. Majority of big centers are carrying out these surgeries with mortalities of less than 0.5%. And it is accepted that the survival curves of these patients match the background population even for 15 years. These are old slides, very well known. Surgical specimens are hard to explain without a video, and I'm sorry about that. But most of our patients are fully immobilized on day 2 after the operation. We carefully monitor the ECG and keep a VVI pacemaker at 60 to protect against complete heart block developing suddenly. Generally, this happens on day 3 or 4. But if the patient comes out in sinus rhythm from the operating room, this has never been a problem. I would skip that, but this slide shows that large centers, whether it is Toronto, Mount Sinai, Mayo, or Cleveland, they come up with mortalities which are really impressive, and with very, very large number of cases. So of the 62 cases that I have done, the average age was 38, 74% male. So far, no mortality. We had a pre-op gradient of 117 and a post-op gradient of 11. These are the peak gradients. Had to reoperate a patient for residual gradients, and I would like to give a little detail on this patient. This was a patient with a very significantly thickened septum, very little view, and he had a residual gradient of 32 millimeters at the time of surgery. I went in and redid a resection, and I could not get through at less than 28. So even though I went in and did a re-resection at the same sitting, I could not get a better outcome. 3 years later, his gradients worsened progressively. This gradient kept on worsening progressively. 3 years later, he became symptomatic with a peak gradient of 75. And I invited one of my friends from abroad who was traveling to India to help me with the reoperation. And at reoperation, we found a 3 millimeter by 4 millimeter nubbin of the septum, which was slightly outside the resection margin, which is described by the experts. And we took that out, and the gradient came down to 12 or something. So that was one great learning, that even if there is a little bit of tissue which is on the outside of the standard described margins of resection, that should be taken out, because oftentimes the anatomy isn't uniform in all patients. I had to carry out a mitral valve replacement in one patient. At the end of the surgery, we found that the mitral regurgitation had not gone away at all. So opened the LA and found an unrecognized mitral valve endocarditis with a perforation in the anterior mitral leaflet. So this patient underwent septal myectomy, and which probably might have been avoided if I had just taken out the mitral valve, and from the mitral valve itself, I could have taken out the part of the septum. There's one patient where we knew that the leaflet height, the posterior mitral leaflet height, was very tall. It was 24 millimeters. Normal is about 14 to 16 millimeters. And that brings the anterior leaflet very much anterior. And at the end of the resection, the SAM did not go away. So I had to go in and resect the posterior leaflet, reduce its height by about 7-8 millimeters. That brought the coaptation of the anterior and posterior leaflets a little posterior. SAM went away, and the patient did well thereafter. We keep the patients in hospital for 8 days, just so that we can take out the pacing wires on the 7th post-operative day, rather than a normal 4. And that is to guard against complete heart blocks. 8 of our patients continue to be class 2. One of them improved to class 1 over time. This was a patient who's the one who improved. She had a mid-cavity gradient of 65 at the termination of surgery. I don't know how to deal with the mid-cavity gradients. I did not know at that time. And we let it be on beta blockers and calcium channel blockers. And this patient progressively improved, and at this time, the mid-cavity gradient is also gone. 3 patients required pacemakers out of these 62. So that's quite a significant number. So my summation is that it's a disease which should be preferred in young patients. Mechanical mitral valve replacement, which is practiced quite frequently, is a very flawed philosophy. You keep the disease which is in the septum and resect the normal anatomy. This is just not the way to do it. Thank you very much.
Thank you. Please, Dr. Sanjay Vichar is there. Comment.
Yes, excellent presentation, Dr. Sujay Shah. Well, I mean, as you highlighted it pretty well, that surgical septal myectomy, no doubt, is the gold standard, and we have excellent results. And yes, my practice, I've been doing it for last nearly 13 years, and well, not a great number, but then close to 58 odd surgeries. And well, as of today, at least, God has been kind. No mortality. I mean, nearly every patient has been followed up by the cardiologist, and they say that things are looking good. My question to you is, how frequently we talk about relocation of a papillae muscle? How frequently, yes, resecting or the dividing abnormal chordae or the papillae muscle is true, but how frequently relocation of a papillae muscle you've done in your cases?
Zero.
Yeah.
But what I do is to make an incision with a scissor between the anterior papillary muscle and the septum,
That's
and
right.
try to release it by about 1.5 centimeters, if that is possible. If that
Right.
is not possible, then we release it at 1 centimeter and call it a day. I think that a lot of people talk about mitral procedures, tensioning the anterior leaflet, lengthening the anterior leaflet, and I have limited experience, but from the experts that I've talked to, it seems to be quite an unnecessary thing unless there is something fundamentally wrong with the mitral valve itself. Like
Right.
we had in 2 patients that one required the mitral valve replacement because we did not know there was an endocarditis there, and the second patient with the excessive posterior leaflet height.
Right. Now, yeah, I mean, yeah, your pacemaker incidence as such is pretty low. What I have seen, like if a patient has a right bundle branch block, the possibility of getting a left bundle is pretty high.
We should be prepared for a 100%.
I know. So if you don't create a left bundle branch block, do you think that your procedure is adequate?
Procedure is adequate if the gradients are
exactly.
So taking the left anterior hemiblock is universal.
Right.
Posterior hemiblock, if that develops as well, then you're going to get a complete left bundle branch block. But that is not something that should bother anyone of us.
Yeah.
And
anyway, great.
And the big people in the game, they say that that is evidence that you've done a complete job.
Exactly.
But not that we'll go after completing the job, completing the left bundle branch.
I do understand. Anyway, great presentation. That's it from my side.
I think coronary artery disease and mitral valve disease are one of the indications for going for myectomy. How do you tackle the coronary artery disease in the same sitting, actually? Or?
So just go ahead and do some bypasses.
Exactly.
And if the mitral valve repair, you do something, or you just replace sometimes very simple.
So repairs would generally be possible because mitral valve regurgitation is almost always as a result of SAM. Yes. And once the SAM is fixed by all that you have done, then mitral valve, like I have had 2 mitral valve procedures and both of them had anatomical issues why we had to do that. For everybody else, the mitral regurgitation settled on its own.
Okay. That's correct.
Thank you, Sujay. I think I'll invite Milind Phadke to go for this first 10-15 minutes we have for the panel discussion with all these panelists will be there. I'll invite these actually. So Milind is there?
Yeah, I'm here, sir, very much here.
You have any questions for panelists?
Yeah, so no, I mean, there were some audience questions, I think, which have been addressed. So I think if any of the senior panelists have any questions, they can please come ahead and ask. We have many senior panelists over here. So if anybody has questions, please.
Dr. Hashim, has there any role for the ERNI or the certain group of drugs for this HCM? SGLTs are coming up like that. Is there any role?
For the ARNIs, it seems to be limited to the patients with the burnt out phase, with demonstrable heart failure with reduced ejection fraction phenotype. But we don't really have data for ARNI or ARBs or ACE for patients with preserved ejection fraction at the moment.
I would like to ask I had an actual live, real case scenario. I had a young lady, strong fellow, brother died suddenly, two mamas died suddenly. She came to me 3 years ago, mild HCM. And she tolerated only 12.5 milligrams of metoprolol, but the resting gradient of 10. She's come after 3 years. She has no symptoms at all. But this time I decided just do a follow-up MRI. And a GLE, which was 9%, now is 20%. Do you need tests, or just with such a strong family history of SCD in the family, go ahead and just put an ICD, or do you want further validation? No, now we need to do further testing to make sure that we're not putting an ICD just for the sake of putting an ICD. With such a strong family history of sudden death, what do the panel do?
I think I'll just sort of take that question first. So I think with the family history that you've described, strong family history in individuals, and the SCD has been attributed to hypertrophic cardiomyopathy, and you're saying that there has been a clear progression of late gadolinium enhancement from 9% to 20%. So if you look at the ACC-AHA risk factor assisted risk stratification process, which looks at 7 primary parameters, a family history of sudden cardiac death, which is attributable to HCM, is one significant marker. And the interesting thing about this 7-marker system from the ACC-AHA is that they are mutually independent of each other.
Yeah.
So in this patient, even in the absence of demonstrable LGE, but 2 sudden cardiac deaths attributable to HCM, that itself would construe an indication for a prophylactic ICD. Now that you've demonstrated clear evidence that it's 20% LGE, then I think it's an absolute indication for a primary prevention of ACD.
Does genetic testing
Actually,
Sorry.
Robin, can I make a comment?
Yeah.
I think lot of Nitin clearly showed that the amount of LG that you quantify is widely variable depending on the machine, the operator, and the experience. And if there's a clear-cut case, when you have a clear-cut case of hypertrophic cardiomyopathy, where you are clearly seeing the thickness of the septum or the maximum thickness on echo, there is no need to rely on the MRI unless you're not seeing something well. Otherwise, just doing MRI just for LG, according to me, is a gross overuse and misuse of MRI, which is happening all around. First investigation HCM is do a MRI. Look at some LG figure in implant and ICD. I think that's the wrong way to go. My question was,
MRI was not done for that.
One second. My question was that relieving obstruction, for example, surgically, or even with alcohol, when you relieve obstruction, does it translate into less progression towards the heart failure stage of HCM? Is there evidence that when you release obstruction, in the long run, there is less heart failure?
I think if we look at, can I take that question?
Yes.
If we look at the long-term studies of septal myectomies, the evidence that patients who have undergone myectomy with less than 30 millimeter mercury residual gradient, they'd have the same outcome at 15 years compared to the background population, would suggest that their heart failure does not progress.
Yeah.
I think, is there a sudden cardiac death also reduction of this actually procedures?
Yes, it does.
Yes.
Yes.
Surgeons believe it. And I have not had to implant an AICD in patients who did not have preoperative indications for AICD implant.
I have one question for the panel, if I may. We encounter patients of pure mid-cavity obstruction who are not responsive to medical therapy. What can we offer them? So these are a big dilemma.
Can I take that question?
Yes, sir.
Yeah. Now, yes, if there is a mid-cavity obstruction, surgery is a treatment. There is no doubt about it. And well, it does. You need to prove that your gradients have gone down. There should be some gradient across mid-cavity. Then surgically, you can take care of it.
At what level from the aortic valve would you be happy to go in, or would you use a ventriculotomy approach?
Yeah, I mean, yes, it is. It takes double the time. I mean, no doubt about it. You need to be extremely careful. But
Yeah,
yes,
I'm audible
to
now.
go,
One second.
I mean, right up to the attachment of
Yeah, now
the papillary muscle to that depth. However, when I'm doing a echo introp, I mean the transesophageal echo, I have fair bit of idea as to how many centimeters I'm going to go down into the left ventricle, and I try and reach that with excision of lot of muscle low down there. Of course, you can't be reaching a full apex, but then I would certainly go right up to the depth of a papillary muscle origin, and you remove. You know the thickness, so less likely that you're going to create a VSD or anything. You need to be, of course, careful about papillary muscle. But yes, mid cavity gradients can be reduced. I think Robin, I recently done a case, and Robin had done an echo just a few days back. He might be able to tell you whether anything changed. Is
Yeah,
Robin around?
it was a case who underwent bypass but had a HCM mid cavity and there were no gradient down. Good job. So I think
But
it's
just done
possible.
a month back.
But
Just done a month back. Yeah.
I can ask of meaning Suresh, mid cavity obstruction can also be addressed by alcohol septal ablation. You can
Yes.
go down to
The,
the
the,
other septal
the
junction. If you
7
find
cases that
one
I have
which
read.
is there, then you can do that also. It has been described. Just saying that
Most of
aloud.
the
And in
cases
fact,
that I talked
could
about,
be a preferred one at experienced centers as compared to surgeon trying to approach that.
yeah, I think yes, the ones that I described, the 7 redos that came to be the last 2 years, were all mid cavity, post septal myomectomy. So
Absolutely.
either the
So
surgeon's
one
not
could address
gone
that.
deep enough to take care of that, or what, I don't know. But they were there and they were all treated with alcohol septal ablation.
So there are only two reasons for residual gradients. One is lack of resection at the outlet. The other is adequate length. So if you do not get adequate length of resection at the time of surgery, then there will be an issue out there. And therefore, the measurements of the length from the aortic valve to the start of the dephasing jet on a CMR or the start of the color signal on echo is very important.
Yeah, I think so, because to me they were all technical issues, because that they didn't go deep enough, because immediately before discharge, when an echo was done on those patients post surgery, they still had a gradient at that time. So clearly, the surgical depth was not enough to take care of the mid cavity areas.
Milind, any more questions for chat box actually?
I think one question Dr. Juwale had asked, can we use triple therapy, beta blockers, verapamil and diazopyramide? Can we combine them in a given patient? So would the panel specifically comment on that?
I think that you do not add on calcium antagonist to beta blocker. You would go with this one. What is the role of giving an additional calcium channel blocker? The disopyramide should come after a beta blocker.
Yeah.
Or for that matter, even mavacamten wise, they give an indication for it after beta blocker and not like adding as a triple therapy. I haven't come across that, at least in literature. Others may want to
Beta
add.
blocker and disopyramide and mecamantine can be combined three.
No, disopyramide or mavacamten. And having said that, for Dr. Hisham, I'm asking of you that now that with mavacamten, you want to monitor your LVEF so closely. And with Yash also there, Yash can also tell us what happens to the LVEF with such disopyramide usage, the kind that you have.
Yeah.
What happens to the LVEFs?
So, sir,
Because it is basically for its negative inotropy, right?
yeah. So if you look at if I were to reference the published data, so the 7.5-year data which I just showed, which was published early this year, there was no meaningful change in the LV ejection fraction in 92 patients who were followed up for a minimum period of 5 years, extending up to 7.5 years. And I think that would be reflective of our experience at our center as well.
Oh, okay. So that fear with now
Yes, yes.
just to play the devil's advocate against mavacamten, you did mention the Marans talking against it in some editorial, and the Marans have caused a lot of harm to us alcohol septal ablaters, I would say, because they dominate the whole business of HOCM because they came from such great centers, right? And now the Sun is also doing the same thing. So coming back to this about mavacamten, in the long term, do you see, because in the natural course of HCM and also those who have undergone septal reduction therapies, eventually they go to the dilated phase probably faster with septal reduction therapies. So what would happen to these guys with mavacamten in the long run?
We really, so we really don't know. So 5 years data is not really good enough to assess long term in terms of new therapy. So I would put it in perspective. Severe obstructive HCM, refractory to conventional therapy. What would be the trade-off, septal myectomy versus myosin inhibition? Currently, I'm inclined to argue in favor of septal myectomy, because I think it's a definitive permanent procedure.
Septal reduction therapy, correct yourself.
Yes, septal reduction.
Why myectomy?
So septal reduction therapy, definitely yes. So so I think it's definitive. We have experience in a large group of patients. There is a lot of data showing, in terms of heart failure data as well. And my cardiac myosin inhibitors is a relatively new kid on the block with some safety concerns. So I don't think the concerns have been addressed adequately in these trials yet. It's expensive. So if it's a trade-off, I would prefer to argue for the conventional septal reduction therapies at the moment. I think mavacamten, we still have a long way to go.
Yeah. Currently, the trials are only 128 weeks, and the whole data is of 5 years only. That's.
Yeah.
Okay, I think we need to move on a little bit now because we have passed our allotted time. So, Dr. Bhavesh, could you please come in at this stage?
Right. Hi. So it has been a fantastic learning from this fabulous CME, which has been arranged by CSI Mumbai branch. And as it is all good things do have to come to an end, it's my pleasant duty to, put forward the closing remarks and vote of thanks. I think, first of all, I would like to thank Dr. Kane, our president, Dr. Milind Phadke, our president-elect, and Dr. Dargad, our treasurer, for having conceived this meeting and gone ahead with such a fantastic, academic layout of the whole program. And I think it would only be apt if I'll ask Milind to, give the vote of thanks to all the, fantastic faculty that we have here. Milind, please.
Oh, yeah. Thank you. Thank you. I have to give the vote of thanks. I start by thanking our president, Dr. Kane, whose drive and vision have led to so many good meetings in such a short span of time, and this will only continue. Dr. Bhavesh for all the hard work as general secretary that he always puts in behind the scenes, and Dr. Dargad for envisaging this meeting, bringing together all the faculty and having such a nice choice of lectures. Strong thank you, Dargad sir, especially. Then our general sponsors, RPG Life Sciences and their team, particularly Mr. Abhinav and Dr. Mangesh. Thank you very much. We are grateful. We have had 5 excellent speakers today. Dr. Kunal, who gave us a very holistic approach to genetics and genetic counseling in HCM. Dr. Burkule, as usual, very comprehensive. He covered MRI and echo in all their depths very thoroughly. Dr. Hisham for a very practical and detailed evidence-based approach to pharmacotherapy. Dr. Vijan sir, always lucid, step-by-step, elegant demonstration of alcohol septal ablation and all its technical issues. And Dr. Shad sir, he's given us so many hitherto unknown insights into the precise details of what seems to be a very, very technically demanding and challenging surgery. And overall, we have had a very comprehensive review, starting from genetics and going up to surgery. And all the panelists, I can't name everybody, but each and every panelist has given extremely valuable insights and inputs into this discussion. And I think overall, I think we can be satisfied with the quality of discussions we have had and all the knowledge that we have gained over the last 2 hours. And we at Mumbai CSI are committed to bringing such programs to you continuously in the future. Thanks a lot for the audience participation as well. And just to announce, we have our next in-person program in May, on 11th of May, which is going to be an actual in-person meeting on ST elevation MI and, difficulties and complicated cases in that. Thank you everybody once more for your attendance and all your patience, and wish you all a good night, and we are going to see each other very soon in the future. So near future. Thanks a lot. Bye-bye.
Bye.
Good night,
Bye.
everyone.
Thank you so much.